I am just another millennial podcaster, which is funny to some degree. And obviously, you have a huge social media sort of presence, which is awesome. And you're super accessible, I think, which is why I was like, you know what, let me ask Ashley if she would like talk about what nurses want to know about like the ventilator because you're in like it sounds like a big like quaternary tertiary care center, certainly with like all the bells
Yeah,
and whistles. And it's like when you get into a bigger, I don't know if you ever worked in like a smaller hospital, but in like a bigger hospital, like the vent and that kind of stuff, like it sort of gets siloed sometimes, like with maybe RT more or
hmm
like we talk about it a lot, but and especially in the past, however many years, right? Like certainly from COVID on, I think we have a lot of like new people like in the space, especially in
for
like the
sure.
ICU space. And I know that like that's one of the things that you talk about. So I was like, you know what, maybe if we just like have a discussion about because obviously people that sort of see you or follow you or engage with you are probably more on like the nursing side, certainly more than
hmm
me, like obviously.
Yeah, for
But I was
sure.
like, you know what, maybe it's like this would be a good time to like talk about like people things that people have to or just like wondering and like honestly you got like a lot of good questions and like some of them were pretty technical which like
Yeah,
I
I was
always
like, oh my
which
gosh.
I always love like maybe if any questions stuck out in your mind
Yeah,
or things that you want to know or like we're always sort of interested in or whatever, so it's more of just like a conversation honestly, so
I'm actually excited to do it, and I think like you're right. A lot of nurses, especially in the United States and like bigger hospital settings, rely so much on RTs, which is wonderful. Like I'm glad we have
right,
RTs, of course, but like where I work, RTs have 6, 7, 8, 9, 10 ICU patients, so there are going to be times where you call your RT and they can't get to you right away. So like I do think
right,
nurses need to have a solid foundation and understanding events and just how to manage them and how to troubleshoot
agree,
and what things mean because you're not always going to have your RT to fall back on,
yeah,
and so
yeah,
but yeah, I think some of the questions that stood out to me um are what people need to know from like a nurse's perspective, but also diving into like a little bit more of the vent settings. And I don't think we need to get like super deep into
yeah,
it. Like
for
just
sure,
kind of the ones that nurses need to know, like the basics.
yeah. The first thing is for you, like let's just say, do you know like what at your hospital, like what kind of ventilators do you use?
We
Did you
have
ever notice?
servos.
You have
Servos,
servos.
right?
Okay,
Yeah.
perfect. Nice. Yeah, yeah. So servo. So first things first is the big vent sort of companies, at least in the US, are servo, like McKay, which is that's the company. Then there's like servo U, servo I. They're a little bit different. They have a little bit different functions. There's Draeger, there's Puritan Bennett, and then the fourth one is like Hamilton. I use servos at the current shop I'm at. Even my previous shop, it was mostly servos and like sometimes like some Puritan Bennett's, but the company itself is like phasing out some ventilators. So the biggest thing is for, getting to know like what vent you're using to some degree is like important. It's important because on the servo, something that's like a nursing thing, and you probably know this, but not everyone might at one point is like, there's like a rescue button, right? If you want to give the patient 100% of FiO2, if you're
hmm
turning them or they're desatting, you're like calling RT or calling whoever the provider is to come see what's happening. And you can press that button, you hold it, and it sort of chirps, and then it gives the patient 100% of FiO2 sort of
Yeah.
off the bat. So just knowing, and to be honest with you, I'm sure there's similar buttons on Draegers or Puritan Bennett's and Hamilton's. Draeger I used like really intermittently. Hamilton's I've never used, and Puritan Bennett's I've used, and I think there was a similar button. But like sort of a rescue, like that rescue, I think is important to know. Obviously, if like they're desatting, you're calling RT and you're doing that stuff. So
For
that's
sure.
that's sort of the first thing. Then depending on the vent that you use, let's just say the McKay servo because that's like the easiest one. It's like the one I use, and I can I don't know the ins and outs of the rest of them because I don't use them as much. But so then we need to think about what are we setting. So from a 30,000 foot view, we're setting a mode. So what do you notice maybe just at your shop? Like, do they use a specific mode? Is it like volume control, PRVC,
We use
pressure control?
PRVC, like that is like what everyone
PRVC,
pretty
yeah.
much gets put on.
So
Yes.
the 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 thing to know about PRVC is that PRVC, so there, this like ties into another question that someone sent me, which was of like a palm crush fellow. So it's like a little sort of more of like a
Provider level
like a
question.
like a just like a thought like a thoughtful question, because
Yeah.
so you might, and you probably don't know, and only because it's like sort of geek stuff, but all these vent companies like PRVC is like McKay's mode of
Yeah.
a certain type of architecture for the breath. It's the same as if you had a Puritan Bennett and you had like it's so with Puritan Bennett it's like VC plus. Then
Yeah.
with Draeger it's autoflow. So all of these sort of same modes just mean that you're going to tell the vent to give a volume.
Yep.
So PRVC is pressure regulated volume control. So we're going to tell the vent to give a volume and then it's going to pressurize to some number to achieve that volume. But the difference is that with those all of those modes, the flow can change, right? So when
Mm-hmm.
the flow changes, which on most of the vents is sort of like the middle graphic. If the
Yeah.
flow is changing, then by definition, it's like a pressure controlled architecture of ventilation, which I get argued with almost daily that like, no, it's volume control because it says it's in the name. I'm like, I know it's in the name, but it's not, it's actually not volume control because in pure volume controlled modes, the flow doesn't change. It's sort of
Yeah.
either like a decelerating ramp or a square. It
Yeah.
can't change. It's a variable that doesn't change with the breath. So if you use PRVC, which we use PRVC a lot, you are probably not in the know with this, which is fine because it's more geek stuff. But I think PRVC is the worst mode of ventilation, and
Yeah.
I'll tell you why. The
Yeah. I
reason
want to know.
is, yeah, I know. Especially if you're in like a MICU setting. So if you have some Meemaw that's on the vent and they're in the like LTAC and they're not doing much, is it fine? It's probably fine.
Yeah.
But the it PRVC and like VC plus and autoflows, the Achilles heel is that as the work of breathing of the patient goes up,
Mm-hmm.
the support from the ventilator goes down. So one thing for the nurse to recognize is if you think the patient's like working to breathe on the vent, especially on PRVC, like they're probably working to breathe. So if
Mm-hmm.
you're like, wow, they're on the vent and they're breathing like 35 times a minute, and you might think to yourself like, they don't look comfortable, they're
Yeah.
agitated. We need to sedate them more. We're giving them more fentanyl. We started propofol. We started ketamine. They're on max dex, et cetera, et cetera.
Yeah.
The fact that they're agitated, they probably are because they probably feel like they can't breathe because they're getting no support from the ventilator.
Yeah.
And they're probably not getting any support from the ventilator because of the mode. Now, you know, do I expect the nurse to sort of be like, hey, Dr. Smith, I heard this guy say that if the patient's working hard on PRVC, like it might be the mode that you set? I
Yeah.
don't expect that. And I think that would be, that's like too much for anyone to sort of be like comfortable saying out loud. But it would definitely be something to sort of, and you know how doctors are, right? Like you can't, if it's not their idea, it's not a good idea. So you have to like really make it their
Oh,
idea.
really?
And
I'm
how,
just kidding.
I know, yeah, I know, right? So how do you do that? So how you do that is, and you probably know this because you're nimble, is you have to be like, oh, do you think it could be the ventilator settings? Like, do you think it could be the mode?
Yeah.
Because I read somewhere that, with PRVC, because when you set a volume, let's say 500, right?
Yeah.
And let's say on breath one, I'm intubated, me personally, and I'm completely passive. So the vent's got to pressurize to some number to put the air into the lungs, right?
Yeah, for sure.
Let's say 30 or something, right? Just as a round number.
Yeah.
Then let's say on the second breath, I wake up, sort of with the snap of my fingers, I wake up, and then of that 30 centimeters of water that you had to provide to push the air in, let's say 15 centimeters of water of that work I do. Like I drop my diaphragm and I help the ventilator deliver the breath.
Yeah.
What the vent's going to think is like, wow, you know what? I don't need to pressurize as much to deliver the breath. So
Yeah.
on subsequent breaths, it's going to pressurize less and less. So the amount of work the ventilator does goes down as the amount of work the patient does goes up.
Uh-huh.
And most of the patients we see in the MICU right? Like they have acidosis, they have ARDS, they have renal failure, they have pulmonary edema from CHF, whatever it is. They're going to have a higher work of breathing for whatever their underlying pathology is. So, if we intubated them for work of breathing and the mode we put them on does less work when they breathe more, then
Hmm.
that's not really achieving the goal of like resting them on the vent, right? Like
Yeah.
that doesn't sort of like help per se. So
So is this where
does that,
you, no, it
yeah,
totally makes sense because like recognized that where patients are initiating a lot of their own breaths, but they're breathing really, really
hmm
quickly. And instead of like, a lot of people jump to like, well, we need to sedate them more. But like if they're on minimal vent settings and especially if they're getting close to being extubated, a lot of times, we either switch them over to like your pressure support mode, or
right.
is this where you would like to use like an SIMV type of mode? We don't use a ton
Oh,
of SIMV where I
that's a
work,
great
and
question.
I actually the other day recommended to not recommended, but to provider said, would you want to put this patient on SIMV? Because they were like taking their own breaths, but they weren't quite ready to extubate yet. Like we
Yeah,
needed to keep them intubated for another
yeah,
day
yeah,
or something. And
yeah.
and he
That's
was
a
like,
great
well,
question.
I didn't where I trained, we didn't use SIMV, so we're not going to
Yeah,
do SIMV. And
right.
I was like, whatever.
That's a terrible that's a terrible answer, right? Like just because you didn't train with it. So so SimV, so this and like there was at least like two or three other questions about SimV overall. So this
Hmm.
is good because it'll answer a couple. So when we think about mechanical ventilators, right? Um, you might have heard of like CMV, like
Yeah.
continuous mandatory ventilation. So so technically CMV doesn't exist anymore because
Yeah.
CMV, if the patient wanted to take a breath, the ventilator would not allow the patient to breathe. Like the patient couldn't trigger any breaths above whatever we set. So if we
Yeah.
set 20 breaths per minute, no matter how hard the patient pulled, they couldn't initiate another breath. SimV, so you have like CMV,
Yeah.
SimV, right? SimV is like sort of as like a broad category, and then assist control. So then the question becomes, what's the difference between SimV and let's say assist control?
Yeah.
The difference is that if the patient initiates a breath on assist control, the breath pattern is the same as whatever you set, meaning if it's volume control, PRVC, or pressure control,
Hmm.
it's gonna be that same architecture, but the patient triggered the breath.
Yeah.
With SimV, the patient triggered breaths become pressure supported breaths, meaning it switches. So you can be SimV VC, you could be SimV PC, you can be SimV PRVC. So the non-triggered breaths are, let's say, PRVC, right? Whereas the
Yeah.
patient-initiated breaths, they switch over to pressure support. So sort of like your whatever you think of pressure support in like an SBT, right?
Yeah.
There's been a number of studies in adults. So peds is a little bit different, so don't hold my feet to the fire with peds. But there's
Yeah.
been a number of studies with adults that because the flow pattern between pressure support and PRVC, pressure support and pressure control, pressure support and volume control, because the flow is different, it's almost like if I blindfolded you and I put this suitcase down and I said to you, Ashley, it's filled with bricks, it's super heavy. You're going to have to really give it all your mustard. And you're like, all right, like I already worked out today, but like I'm going to lift this thing up, right? So you can imagine you'd probably in your mind, you'd be psyched to lift up this really heavy thing. Let's
Yeah.
say I played a trick on you and it was empty. So you would like put all this force into lifting the suitcase up, and then you would like pull it with all your might and it's empty. So you would like, launch it into the ceiling or something.
Yeah, for sure.
So similarly, when with SimV specifically, if you're switching between these breath types and
Yeah.
these flow patterns, the brain can't like anticipate the loading pattern. So
Yeah,
what
I see
that
what you
mean
mean.
so what that means is that there's been sort of like they've done studies where we've dropped esophageal balloons and seen how much work people are doing on each breath type, and people do more work with SimV,
Yeah.
like by the calculations they do. And if I think if you plucked any intensivist off of the face of the earth and said, what's SIMV good for? They would say like, oh, weaning because the patient does some of the work and the vent does some of the work.
Yeah.
That turned out like not to be true. So to answer your question, if you're on like a PRVC type mode, right, and the patient's getting better, but they're breathing for themselves, and you don't need to control their volume, right? If they had ARDS, they're getting better. It doesn't need to be 60 Cs per kg anymore.
Hmm.
My general approach is I usually either just go to like pressure control and then let them
Yeah.
breathe sort of what they want, or you're right, like decrease the sedation, wake them up, have them RAS 0, -1, and put them on pressure support and just like sort of let them breathe what they want. So
Yeah.
generally the most comfortable, and this is a broad stroke, so don't really like, don't sort of like hold me to it, but if the patient can breathe spontaneously, the most comfortable thing for them to do is going to be pressure support because
For sure.
control their inspiratory time. So we're not,
Yeah.
the most freedom a patient has is on pressure support.
For
So if
sure.
you're noticed, and a lot of times we see this too, and you probably see it as well, is if you have a patient that you intubated and they have like renal failure or something, right? And their pH is like 6.9.
Yeah.
If you put them on PRVC, you're going to be torturing them without a doubt because
Yeah.
they're going to be breathing so much that the vent's going to be like, wow, I don't have to like pressurize at all to deliver this volume. But
Yeah,
that's
for
because
sure.
like the patient's doing a bunch of work, not the
Yeah.
ventilator.
Yeah.
SIMV doesn't really, it has some role in peds. In the
Yeah.
adult world, less so, certainly.
Yeah, that makes sense. I had a good question I thought that we could talk about is someone was like, what's the difference between pressure support and pressure control? Because I feel like we
Oh,
throw all these like
so
random,
good.
pressures and
Yes.
volumes and all these things. So
Yes.
like,
Yes.
we can talk about differentiating between the two
Such a
because
good
they are
question. They're
quite
so they're
different
they're
in a
yeah,
lot of
yeah.
ways.
They're different. So so that's such a good question because, and this comes up not infrequently. So pressure control, pressure support. So the first branch point is that pressure control, we set, and this, we can sort of like work this into the other question, which is like all the settings.
Yeah.
So when you have like a pressure controlled setting, right? What are we setting in pressure control? So we're setting a respiratory rate. So we'll set
Hmm.
20 or something. We're setting a PEEP. So 5, whatever your PEEP du jour is.
Yep.
We're setting an inspiratory pressure. So it's like, it's the same as BiPAP, right? We set an
Yeah.
EPAP and an IPAP. So pressure
Yep.
control, we're setting an EPAP, PEEP. We're setting an IPAP. There's a lot of colloquialisms, like some people call it the pressure control setting, some people call it the inspiratory pressure, some people
Yeah.
call it the pressure applied. Even more confusing, some people call it the driving pressure, right? So,
Yeah.
which it is and it isn't, but it's like really confusing. So I try not to say that terminology.
Yeah.
But whatever you call it, we set that as well. We set an FiO2, and then the other thing that we set that is more sort of geeked out, certainly, is we set the inspiratory time.
Hmm.
So how long the breath is going to be. Normally it's like 0.8 seconds to like 1.2 seconds is like the book definition.
Yeah.
I tend to set it at like 1 second if I'm going to set it, just because it makes the math, if I'm doing math, easier. Just 1 second, right?
Yeah.
In pressure support, now what's the difference? We don't set a respiratory rate, so it's
Hmm.
a spontaneous mode of breathing. So the patient has to initiate all the breaths. We still set a PEEP, so we set an EPAP.
Yep.
We still set an IPAP, or pressure applied, pressure control, whatever you call it. We set an FiO2. We do not set an inspiratory time.
Because it's
So then how,
spontaneous.
because it's spontaneous, but then the question becomes, how does the vent know that Nick doesn't want to breathe anymore? So what we do set is a percent decay of flow from the max, meaning
Hmm.
when you first take a breath in that first like millisecond, the pressure difference between your lungs and whatever pressure we set is the largest. So
Hmm.
the flow will be the highest, right? In that first millisecond. That first upstroke of the flow, it's the highest. So you can tell the ventilator you want to cycle into expiration at some percent decay, meaning let's say I took a breath in and the height of the flow was 100 liters per minute. If I set the ventilator to cycle into expiration at 50% of that max, it would cycle at 50 liters. So
Hmm.
as my flow slows down, once it hits 50, it cycles into expiration. So that's how the vent knows to go from inspiration to expiration.
Okay.
BiPAP is a little bit similar. We don't set that, but each BiPAP machine, so there's like Philips and like McKay does BiPAP. You can set a
Yeah.
BiPAP setting on it. Um, there's Philips, there's like the V60, all these different BiPAPs. They all have like specific algorithms to figure out how the vent cycles into expiration. Now, to sort of bring it home, the difference between pressure control and pressure support isn't really much. The difference is one of them, the patient has to breathe on their own
Hmm.
spontaneously. The other big difference is that in pressure control, we set the inspiratory time, one
Yeah.
second, zero point 0.5 seconds. In pressure support, the patient's flow decay is the inspiratory time.
Yeah.
Now, when's that important? That's important if you have patient with like emphysema, right?
Hmm.
Because remember, if you have emphysema, your compliance is so good, meaning you don't need that much of a pressure change to drive flow, right? You
Yeah.
just need a little bit of a pressure change to drive flow. So if you make that cycling mechanism too low, meaning let's say we said 50% before, let's say we made it 10%, right? So they would have to get to 10% of the max flow.
Hmm.
With a patient with emphysema, they may never get to that because they're always going to have flow. So
Yeah.
what you wind up doing is trapping these people in inspiration because they'll never get to that decrease in flow. So they're just trapped. So this is one this is one thing that people like, you know, I'm not going to say nurses because it's like unfair to characterize that, but I mean attendings, residents, fellows, like
Hmm.
they might know like, yeah, we said an inspiratory flow decay, but if I'm like, what does that really mean? It's just
Yeah.
completely over their head. But it does come into play in some situations, specifically emphysema.
So like, and just to try to tie it into where I think this would benefit nurses. So like your emphysema patients, your COPDers, they're retaining CO2. They're trapping that kind of in that lung space. So is that kind of what you're talking about is if you wait too long for that full exhale, they're never going to exhale enough to get that CO2 out. Is that kind of what?
So this, yeah, and that's a good point, which like ties into another point, which is, and so it's ICU specific certainly, but CO2, especially in like emphysema or chronic retainers, we can set the ventilator to whatever we want to get the CO2 to some normal number.
Yeah,
But remember, if we're ventilating patients like unsafely to get normal numbers, that's like the reverse of what we want.
for sure.
With pressure support specifically and emphysema, if we have the PEEP at let's say 5, right? And
Yeah,
we have that sort of delta pressure and let's say 10, so like 10 over 5,
yeah,
right? When you provide that extra 10 of pressure, because the patient with emphysema's lungs are so compliant, like they open up so easily.
hmm,
If they have to get down to like, let's say it was 100 and we set that cycle decay, that percent at 10%, that means that they would have to drop the flow all the way down to 10. And
yeah,
they may never get there because when you give them that much pressure difference, they are always going to have flow going into their lungs. So that inspiratory time is going to be super duper 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 long. And for
hmm,
the patient, like they're already full of air, so they want to exhale, but the ventilator is not getting the signal to go into exhalation. So
yeah,
what's important, I think, is if you and I think like, you know, if you take nothing from that, if you have a patient on pressure support and it's a patient with COPD, and the normal is going to be like, oh, they keep failing because they're tachypnic or they're agitated or something.
hmm,
Think about like it would just be to bring up like, hey, are we sure these pressure support settings are right for the patient with emphysema?
yeah,
Because they need to be tinkered with just a little bit to help the patient with emphysema get off the ventilator. Would
for
probably be
sure.
like
So
would be good to bring up.
So what is your kind of go-to for a pressure
For
support
that,
mode
yeah,
for a patient that's got really bad emphysema?
good question. So there's there are a couple studies on this. Not like they're not like groundbreaking, they're not huge, but there's like maybe 20 patients. So you
Hmm.
remember how so we can set that percent decay at whatever we want. We can set it at 75%, 50%, 25%. So
Hmm.
with patients with emphysema, they do the best if it's at 50%. So let's say
Okay.
Mr. Jones, Mr. Jones, he takes a breath in, it gets to 100 liters per minute, right?
Yep.
Instead of making him get to 10, we make him only get to 50, and then he cycles off into expiration. So
Okay.
there's like some studies that there's like some by like one or two, and they're not great, but there's at least some evidence that if you make that cycle percentage 50%, so like not too high, not too low, but sort of Goldilocks, like just right,
Yeah.
they do the best with like worker breathing at that number. So and you might ask, like, do you do that? And like, I do that. If I have a patient who has emphysema and they're on the ventilator and now they're on pressure support,
Hmm.
I purposely go up to on the McKay. You can ask the next time you're working, ask RT to show you where the flow decay percent is. So
Yeah.
on the McKay at the bottom, where like we sort of set everything,
Yeah.
there's a little arrow that has like a little dash mark. If you press that over on pressure support, you can dial in how much percent decay you want. 30%, 25%,
Yeah.
50%, 75%, whatever it is. So I'll change that. On the McKay, it's usually set at 30% is like sort of the is like the setting out of the box.
Yeah.
So I will make that 50% in patients with emphysema because I know that if we make them get down to 30%, we might be trapping them in inspiration. They feel like they can't
Yeah.
breathe. Because imagine you had a tube down your throat and the ventilator is just on and there's just air coming at you like nonstop and you feel like you can't exhale, right?
Hmm.
That would be like incredibly anxiety producing. So,
For sure. And I feel like a lot of this is being stereotypical, but I think it's so common. A lot of people will relate. A lot of COPD patients are anxious at baseline
oh
because
yeah.
of their breathing. So
Yeah,
then you put them on a ventilator, you wake them up, you try to get them off the ventilator. They're anxious because they're anxious at baseline, but now they have a hard time breathing, which makes them, it's like a spiral. And I think one thing that I teach a lot of nurses that I precept is anxiety is not a reason to not get someone off the vent. A lot of people think, oh, they wake up, they're anxious, they're agitated, they're all those things, which, yeah, so in some cases, sure, it might be a reason why they're not ready to come off. But in
right.
a lot of cases, like we need to tweak the vent settings or get some better concoction for them to help them feel calm while they're doing their like spontaneous breathing trials because else they're going to fail all the time. They're going to fail every day. I mean, the
And
anxiety is not going to go away.
yeah, and then like I know, unfortunately, like in the SAT, in SAT, like if the wake up and breathe protocol
Yeah.
that was published probably like I mean it's a while now. It's probably like 2012 or something or 2017. I forget.
Yeah.
But what one of the one of the contraindications to SAT is agitation, right? And
Yep.
I don't know what that I don't know what that means because like they're all going to be agitated,
Everyone's
just like the
agitated.
way
Yeah.
I know, like we're all agitated. We all need a little bit of Precedex, but like
Yeah.
you know with patients with COPD, certainly my my level of like the bar they have to clear to get off the ventilator is much less. Meaning like I know for as you say, like they're anxious, they're agitated.
Hmm.
Their SBT might not be pristine, but if it's passable, I'll usually just extubate them, knowing that if we get the tube out, it'll be better than having the tube in, like most of the time. If they check all the
For
other
sure.
boxes, right? Like their pneumonia's better, their diaries, et cetera, et cetera. If we're
Yeah.
just standing there, they're breathing like 30 and they're like awake, alert, and that you could just tell that like, man,
They're
if I
like
get this
looking at
damn
you like,
get this tube out and you're like, I don't know, they're breathing 30, they're belly breathing, I can't tell. I can almost guarantee you if you get the tube out most of the time, I mean it might be a little rocky from sort of like having the tube in to getting it out, but I think most of the time if you get the tube out, they do much better with it out, as you say, which is
for
why,
sure.
I hate intubating patients with COPD because you really like they're really at a disadvantage when we do that stuff
Hmm.
because
For sure.
they're like they already feel like they can't breathe. Now they have this thing down their throat. Now they're getting air pushed at them sort of like all the time. So
Yeah.
I agree, dude. I try to get the tube. I'm much more aggressive about getting the tube out in patients with COPD than like. I mean, I'm aggressive generally, but I'm even more aggressive with them because
For
of the
sure.
reasons you say.
So I hear in like this whole air not being able to fully exhale, that is what you would call air trapping, because I feel like that gets thrown around.
Such a good point. Yes, that's exactly what it is.
Yeah.
Sadly, I've sort of made my whole
Or
personality
breath
about it. So
or breath
yeah.
stacking, right? I hear breath stacking and they just keep kind of building up and like
So
sorry, go
no, go
ahead.
ahead. Breath stacking. No, these are good. So maybe like colloquialisms, right? So like breath stacking. So like breath stacking, double triggering,
Yeah.
bucking, right? These are all like bucking, maybe not so much because I feel like some people say bucking when the vent's just like beeping, right? It's
Yeah,
just the
because they're
vent's,
coughing and they're,
yeah, exactly.
whatever.
But like, but if they cough and the vent's honking, like that's not exactly like that's like normal stuff, right? Like
Yeah,
that's
for sure.
it's gonna honk. Um, so breath stacking generally means like a double trigger. So
Hmm.
you go through breath and then the patient still wants to breathe. They still want air. So they contract their diaphragm so forcefully that they can
They take a
trigger
breath
another,
on top.
trigger another breath, right? So
Yeah.
you can imagine if you've gotten two breaths that you might not be able to exhale all that volume, which brings us to the next point, which you bring up is that
Air
if you don't
trapping.
get air trapping, if you don't get all the air out that we put in, and we can do this sort of like very specifically, but as a general broad stroke, if you don't get all of the air out that we put in and some is left over, and then you start another breath, that air exerts a pressure, right? And
Yeah.
it's more pressure in expiration that than we set. So we set a pressure in expiration. We call that the PEEP. If
Yep.
you have extra pressure above the pressure that we set, we call this auto PEEP.
Auto peep. Yeah.
Exactly. So, and that's from us not getting the air out. That's generally a problem with time and expiration. So if you
Hmm.
don't get all the air out in expiration, it means that we didn't have enough time in expiration. So patients with COPD, asthma, and like any obstructive lung disease, like they need more time in expiration to get
Hmm.
the air out. And if we don't do that, then we put them at risk for getting auto PEEP, which comes with a bunch of sort of issues. Notably, and this is for nurses be something to recognize, sort of like the end game of auto PEEP, sort of like the worst thing can happen is hemodynamic collapse. So
Yeah.
if you have a patient who has asthma or COPD and you notice, wow, they're really tachycardic, wow, their blood pressure just dropped. In the back of your mind, you need to be thinking, do they have auto PEEP? Because more pressure in the chest decreases venous return.
Cardiac. Yeah. And decreases
Yep,
your cardiac output.
decreases cardiac output, your blood pressure goes down. Either that or even worse, now they have a pneumothorax, which is essentially the
Yeah.
same pathophysiology, but obviously different treatment.
For sure.
So it's certainly important to recognize for sure.
So, I have a question kind of back to COPD, but along the same topic.
Yeah,
So, like I said, we typically put everybody on PRVC, even if you're a COPD or like everyone starts on PRVC, and then
yeah,
a lot of times the COPDers transition over to pressure control. Typically, what I see is they're peak pressuring, their volumes are limited, they're not getting their full volumes, and so
right.
then we transition them over to a pressure control mode. So, can you like kind of walk it through like from a nurse's perspective as far as like why is that happening? Because I was always taught like, well, it's a compliance issue, but obviously their lungs are super compliant. It's
So
just that,
how's that a compliance issue?
yeah, so what?
That is, yeah. Oh my God. This goes part and parcel. Like I did this every day for almost 2 years because this would happen a lot. So auto PEEP happens when we don't have enough time in expiration, right? Okay.
Yes,
So we can agree on that. Now,
agreed.
yeah, right. When you have a patient with COPD, the one thing that we've learned, that we've all learned, nurses, RTs, medical students, is that patients do this like pursed lip breathing, right?
Hmm.
Because they're trying to sort of generate this PEEP intrinsically to keep their alveoli and their bronchi to some degree open, right?
Yeah.
Now, also what happens with COPD is that, and emphysema, is that some percentage of the lung doesn't work anymore, right? I don't know. Let's say 50% or something.
Yeah.
So now patients with COPD, if they have like real COPD, emphysema, they generally breathe bigger breaths, but much slower, right?
Hmm.
So a patient with COPD, they might take, a 700 ml breath, like not intubated,
Yeah.
and they might breathe, I don't know, like 10 or 15 times a minute, which is like sort of on the lower side, right?
Yeah.
So, but if you did the math, you would say that, their minute ventilation, like how much they're breathing per minute, sort of like the cardiac output of the lungs, is like how some people describe it. It's not a bad thing. Um, it's a little bit higher than normal because depending on your gender or your sex, how tall you are, sort of like your metabolic need, a
Yeah.
normal minute ventilation is like 5 to 7, right? So they're on the higher level. They're on the higher level because half of that minute ventilation of, let's say, 8, so 4 liters of it is completely useless because half of their lung doesn't work, right?
That dead
So
space,
the
right?
dead space, beautiful, exactly.
Yeah.
So they have higher dead space, so they need to breathe more to achieve the same alveolar ventilation, right?
Hmm. Yep.
So let's stick with this example. So we have a guy, Mr. Jones, let's say. His total volume normally is like 700. He breathes about 15 times a minute, and he does okay. Sadly, he gets intubated. Now, and I don't know how it is at your shop. It's a little bit different everywhere, but some shops are cheating more towards like this low tidal volume ventilation situation
Hmm.
because they think it's helpful in all situations. I tend like not to really agree with that because the data hasn't borne that out. Nevertheless, some places start out at 6 cc's per kg or
Yeah.
7. So let's think about this. Mr. Jones now gets intubated. Let's say we put him on a total, and let's just make the math easy because I can't do math because I'm that stupid. But let's say we cut his total volume in half
Yeah.
because Nick is the fellow or the attending on, and we're like, we want to do low total volume ventilation. So let's make his total volume now 350. To achieve the same minute ventilation, how much does he have to breathe?
He's gonna have to breathe a lot quicker because of all that
So
dead
we
space
have
in
the
there, and
we
yeah.
have the volume, so we got to double the rate. So we
Hmm.
went from 15 to 30. So
Yeah.
now, if we agree still that auto peep is a rate issue, he was breathing 15 because if he breathes any more, he's going to get auto peep, right?
Yeah, because he
So
can't fully
now
exhale.
he can't fully exhale. So now we're forcing him to breathe faster because we've made his total volume much lower.
Yeah.
So what happens? What happens is we get auto peep. Auto peep, so extra pressure in the chest, by definition, makes your compliance lower.
Yeah.
So as the patient breathes faster, as the auto peep builds, PRVC, let's say, because it's the worst mode, so we'll just bag on that for a minute, it has to pressurize more and more and more and more to deliver the volume.
Yeah.
And even worse, if the patient's breathing, they're going to breathe faster and faster and faster to get the same volume. So generally, I'm gonna guess what happens is when you switch them over to pressure control, they take a much bigger breath, but much
Hmm.
slower, right?
Yeah, for sure.
Which for me, I would rather that. I would rather a bigger breath, but much slower,
Yeah.
especially in patients with emphysema or COPD.
Yeah.
So it
Um,
happens all the time.
no, that actually makes a lot of sense. I'm like a big visual person, and will this be a video too, or people can be able to see it as a video?
See us?
Yeah.
Yeah,
Yeah. So like I think of it like I describe your alveoli like is a circle, and in your
right.
COPD patients, they're all so like
Yes.
overly stretched and whatnot,
Yeah,
and so they're not able to like squeeze out that.
right.
This is my visual CO2 very well. So then I'm thinking when you're on your PRVC modes
Hmm.
and you have that low tidal volume and you're already overstretched and now you're auto peeping. So now you're really overstretched. Like
Right.
you're not able to properly exhale well. So it's
Well,
like
Matt, you want to
a
do
bad
something even better?
cycle.
You want to do
Yes,
something
I
better?
do.
Want to do an experiment? Okay. So I want you to take the biggest breath you can in, all the way up.
Okay.
Stop there. So take it all the way up and then hold it.
Okay.
Now only exhale 10%. Now do take a biggest breath all the way up. Now only exhale 10%. Now take another biggest breath all the way up. So how does that feel? That
It
feels
feels
terrible,
like,
right?
yeah, it feels
So
like I have
that's
a ton of air in my lungs.
so that is exactly what our friends with COPD, asthma, that's what they feel when they're obstructed. Because when you're obstructed and you have auto PEEP, you are, and certainly with certainly with emphysema much more than asthma, but this it's like the same thing applies.
Yeah.
So whenever like an intern, resident, whoever, they come up to me and say, Mr. Jones has asthma, like he's just agitated though. Like I think he's fine, he's agitated, blah blah. Or he's anxious, like we should just give him some like Ativan to calm down. I'm
Yeah.
like, he feels like he can't breathe. And
Yeah.
they're like, oh, yeah. I'm like, no, I don't think you understand. Like, he feels like he can't breathe. So I make them do that in front of me. And then
Hmm.
by the end of it, they're all like, oh, okay, like I get it. Like, that is a very uncomfortable feeling.
For
So
sure.
it is super uncomfortable to be breathing closer to your total lung capacity. So you sort of get this stretch response from like your diaphragm, your intercostals, and you feel like you want to exhale and you can't because if it's asthma, you can't get through these like really tight bronchioles because of
Yeah.
inflammation. If it's emphysema, to your point, their alveoli are so stretched because all of the elastic properties of them are gone, so they can't collapse down. So they just keep getting stretched and stretched and stretched and stretched. The diaphragm gets flatter and flatter and flatter and flatter. They get bigger and bigger and bigger lungs, and they feel like they can't breathe out, and they can't breathe out. They're
Uh-huh.
right. So
Yeah.
it's incredibly anxiety producing, but it's not like because Mr. Jones has like a history of anxiety or something, right? It's because like he
Yeah.
feels like he can't breathe, and he's 100% right. He can't breathe
Yeah. Yeah. For sure. That's really cool. Yeah. Cause I noticed a lot of your, like, a lot of asthmatics. We get a lot of young asthmatics in
for
particular, I
sure.
feel like, it's kind of
Yeah.
the population. And they will breathe like 7 times a minute because like exhaling just like so
No, and
slow.
that's exactly like what they need to do.
Yeah.
So
But their tidal
that's
volumes are
like
huge.
right, and they're total volume. So and this comes into the like the COPD like point of it is that I think if you went up to I think if you plucked an intensivist out of the street and said, and if you said a number, if you said like 600 ml total volume, I think most of intensivists would be like, are you sure? Like that seems pretty big,
Yeah.
right? But remember, this total volume thing, like this low total volume ventilation stuff, that's really in ARDS, right?
Yeah. Yeah.
So
Yeah.
so definitely patients with COPD, and then patients with asthma who are younger, they have normal volume. I mean, sorry, they have normal lungs. I mean, if they're not like in asthma exacerbation, it's different. But what I'm saying
Yeah.
is that you can give them a 600 cc total volume, and you're not gonna, your plateau pressure. And someone asked me to like us to explain plateau, which I can do. So your
Yeah.
plateau pressure, which is the pressure in the alveolus after inspiration.
Yeah.
So after we deliver a total volume, we do an inspiratory hold. Depends on what vent you're using on how you do that. But you hold inspiration, so you're kind of holding that air in. Then the
Hmm.
vent will transduce a pressure. So almost like a swan transducing pressures sort of downstream. So you can say, is there a lot of issues with that? There is a lot of issues with that, but it's what we got. But
Yeah.
that pressure, after we give a volume, we hold it in, we transduce the pressure, that's the plateau. In ARDS, we've come to recognize that that number is important. That number being less than 30 is like really important. But
Yeah.
most patients with normal compliance with sort of with like a 5, 6, 650, so somewhere, 7, 8, 9, 10 ml per kg, that size total volume, even though it's bigger than I think like we're normally used to, if you have normal lungs, it doesn't really, it's not really an issue. So if you have a young
Hmm.
asthmatic, as you mentioned, and they need like they can't breathe any more than like 7 or 6 times a minute, which is like pretty damn low, right?
Yeah.
Without them auto peeping and dying, you're going to have to make their volume higher because you got to satisfy their minute ventilation needs. So the only way to
For
do
sure.
that is to give them a, you know, like 5, 6, 650. I tend to get nervous around like 10 ml per kg.
Yeah.
I'm like, I don't know, like this is getting pretty big.
Yeah.
But I've dropped people to, I think my lowest rate was like 5, and that's like pretty low, right? And
That's
and
super
our,
low.
I know, And RT is like, they're like very nervous. They're like, you're going to like kill this person. But when you recognize, as you point out, they have such a long exhalation time. And
Mm-hmm.
all these things you can calculate and like be very specific about it. But they have such a long exhalation time that if they breathe any faster before you fix their asthma, they're going to auto peep. And then
Yep.
at the very worst, they can either have hemodynamic collapse or have barotrauma.
Yeah.
And then if they have barotrauma, it's like, if they get a pneumothorax, it's like so much worse. Just makes
Yeah.
things 1,000 times worse.
For sure. Since we were talking about ARDS, I had a couple questions about APRV, which I feel like is a mode that we like, you see a lot in ARDS, but you don't see it every single day. So it's a
Yeah,
mode a lot of nurses are not super familiar with. And I also think it's
yeah.
a very like unique mode compared to everything else. Like they don't, I don't
Oh, it's a super
remember
unique mode.
learning. I don't remember learning APRV in nursing school because it's just not one of your like standard modes that is you just throw
Yeah.
a patient on
No,
randomly.
that's a great. It's someone. I don't want to say older. I'm going to say seasoned nurses. I don't want to insult anyone, but our seasoned nurses might remember pressure control with like inverse ratio, like inverse ratio pressure control.
Uh-huh.
Meaning, generally in mechanical ventilation, your inspiratory time is lower than your expiratory time.
Yep.
Okay. In inverse ratio pressure control, you make your inspiratory time longer.
Mm-hmm.
Why do we do that? At the crux of this is, I think, and you probably asked like, student nurses this, and I asked residents and stuff, what makes oxygenation better? And we usually think about FiO2 and PEEP.
Yep. Mm-hmm.
The PEEP part is like half the story. Because when it really comes down to is your mean airway pressure, meaning if your mean airway pressure, the pressure in your airways, sort of like its average, is
Yeah.
higher, then you're essentially pushing harder against the oxygen to sort of like force it into the blood. The question is, how do you increase mean airway pressure? You can increase it in a couple ways. You can increase the PEEP. You can increase the highest pressure you apply, like your peak airway pressure,
Yeah. Yeah.
or you can increase the time that you spend in your peak
In
pressure
inspiration.
in
Yeah.
inspiration. Exactly. So with pressure control, if you increase the time you spend in your peak airway pressure, you're increasing your mean airway pressure. So APRV, which is airway pressure release ventilation, which like is sort of like I'm trying to like APRV is sort of its name, but in different vents it could have like different names, which gets confusing. But
Yeah.
nevertheless,
Why do they do that?
because so that's a great question. They do that because each vent company has its algorithmic. It's like that algorithm is like proprietary to their company, so they patent it and then they call it PRVC. They call
Yeah.
it VC plus. They call it whatever, and then it's patented to their ventilator, and then they just like go on. So that's why it's like kind of annoying. Which gets back
Yeah.
to the other question, which is like not to sidetrack, but Cleveland Clinic actually has this sort of like ventilator taxonomy. So instead of like saying PRVC or APRV or like volume guaranteed stuff, they break it down by specifics more precisely that give it like a tag. So it's
Mm-hmm.
kind of like naming it from like a taxonomy standpoint and not using the vent machines like verbiage. So that's a whole separate issue. But APRV, we're setting a pressure high, P high.
Yes.
We're setting a P low, generally zero.
Yeah.
We're setting a time high, how much time we spend in inspiration, usually 2-ish seconds.
Mm-hmm.
Then we're setting a T low, a time we spend at the low pressure. So let's break this into two separate situations. So the time that we're spending at P high is the time that we spend recruiting lung. So we're
Yeah.
recruiting lung by applying pressure to the alveolus to get it to open up.
Mm-hmm.
Maybe it's filled with edema. Maybe it's filled with pus. Maybe it's filled with other inflammatory junk that
Yeah.
causes it to collapse down, right? So we want to recruit it up. So we apply pressure. How long we can do that? So if we do that for 2 seconds, right? And this gets really confusing, but just try to follow. And we're not going to do real math, but I think you'll be able to parse it through.
Yeah.
Let's say we let's say we spent 2 seconds at the P high. Let's say we spent zero point 0.5 seconds at the P low. That
Yeah,
means that
that's
our
quick.
so that
That's
and
quick.
right, and that'll get to like the other part of APRV. But if we
Yeah.
spend 2 seconds at P high, inspiration, we spend zero point 0.5 seconds at P low, expiration. That means a total breath time, inspiration, expiration, is 2.5 seconds, right?
Yeah.
2.5.
Yeah.
If we have 60 seconds in a minute, 2.5 seconds, that means our respiratory rate is 24, right?
Hmm.
Then if we start to fiddle faddle with that, with those numbers, we're going to change the respiratory rate, right?
Yeah.
So
Yep.
another thing we got to keep in the back of our mind is like how much time we're spending in each, because that'll affect our respiratory rate. Why is that important? That's important because I think you might agree, anecdotally at least, if someone has ARDS, we're usually breathing like 26, 28, 30 times a
Hmm.
minute, right? So we're really
Yep.
limited in APRV by how fast we need to breathe, okay?
Yeah.
So APRV in of itself is just those four settings, okay?
Yep.
The theory behind it is that as you recruit lung, as you sort of recruit these alveoli that were collapsed and now you recruit them up, they start to participate in gas exchange.
Yeah.
So remember, as you gain more lung that participates in gas exchange, in some ways that means that your compliance is getting better, right? Your compliance really stinks because you need a lot of pressure to
Hmm.
generate a volume. If you are now generating a bigger volume with the same amount of pressure, your compliance had to have gotten better, meaning your
Yeah.
lung is working better, right? Okay. Now, that's APRV, right?
Yeah.
TCAV, this time controlled adaptive ventilation, that's a separate that's a separate but related concept. So this comes out of a lot of stuff that like Maryland does, which is where Hibashi is, who does a lot of like research into APRV TCAV. So
Hmm.
the TCAV piece of it is, now take it for what it's worth, but what we've seen in pig lung is that if we trap 75% of the peak expiratory flow,
Yeah.
if we end expiration at 75% of peak expiratory flow, you generate auto PEEP, which is what you want. You want to generate pressure. So as you are recruiting lung during inspiration with pressure, you're also not losing that pressure in expiration. Because if all your flow leaves
Yeah.
and all your volume leaves, would you agree that if we exhale all the volume, all the pressure is gone, right?
Yeah.
So
For sure.
we're not recruiting anymore. So APRV, TCAV, APRV itself is those four variables. TCAV is this theory that if you have this peak expiratory flow of some number, let's make it 100 just because the math is easy.
Yeah.
So in expiration, if you expire at 100 liters per minute, 75% of that would be 75. So
Hmm.
what you would do is on the vent, depending on the ventilator you have, Puritan Bennett, McKay, Drager, Hamilton, once you get to 75 liters per minute, you cut exhalation off and then you go back to P high. So you're trapping,
Yeah.
what you're doing is you're trapping flow, creating auto PEEP, creating pressure.
Yeah.
So the crux of this is that you really need to know what you're looking at on the ventilator to do this mode, which is why a lot of people, intensivists, respiratory therapists, pulmonologists, whoever's running the vent, this might be shocking to you, but I think the ventilator is certainly one of the least understood things that we do in the medical ICU, definitely.
Hmm.
Like, we all sort of have this working definition, like plateau pressure, PEEP, etc. But
Yeah.
what I found is that when we really get into the nitty gritty, it's really not that well known. And APRV is like, you really need to know what you're looking at to really apply it correctly. So for, the best, and so I think I heard this on a podcast recently, but I agree with it. The best ventilator mode is the mode that everyone understands. So even
Yeah.
though like I can come in and say, Ashley, we're going to do APRV, we're going to do this, we're going to do that. And you're like, oh, okay, that sounds great. And then,
Yeah,
but you don't know what is he doing? Like,
for
how does
sure.
that helpful?
Yeah,
If you understand or can at least recognize volume control or PRVC and like, wow, that peak airway pressure is like really high. Like that must mean they need to be suctioned. That must mean,
yeah,
they're biting on the tube. That must mean something. That's better because you have eyes on the patient all the time, right? What do?
yeah,
I come in, we round for 15 minutes. I complain about something. I go on a soliloquy about something. And then I go back to the call room and like drink coffee and then come back 6 hours later, then yell about how the residents didn't diurese the patient enough, right? Like
yeah,
you're there all the time. So why would, like for me at least, why would I put the patient on event mode that, that you're not comfortable with or like RT isn't comfortable with? Like
yeah.
that's probably the worst thing that we can do. You know what I mean?
For sure. A lot of times I've noticed that with APRV, and this is, you'll think this is funny. I remember like years ago, my first APRV patient, we get an
Yeah,
ABG, they're acidotic because a
yeah,
lot of APRV patients are
yeah,
acidotic.
right.
So maybe we can kind of talk about that because I remember going to the intensivist and they're like, just put a conditional order, allow for permissive hypercapnia. And I'm like, are you sure like their pH is like 7.25 or, whatever it was.
Yeah, yeah,
And it was, but then I learned, why we have allow for permissive hypercapnia in these patients
yeah,
because of that type of vent mode that they're in
yeah.
naturally makes
And
them a little more acidotic.
permissive hypercapnia in and of itself is the name of the game with so if and again like specialty ICU is a little bit different. So certainly CV ICU, forget it. Like you can't say permissive hypercapnia, they'll have like a heart attack. But like neuro ICU is not great. And
Yeah,
then
yeah,
so with neuro stuff, you can't really be permissively hypercapic. It's not a great idea.
yep,
Um, with RV failure, as you probably know, not a great idea to be permissive hypercapnic. So
yep,
those situations not great. But ARDS and let's take ARDS and asthma as sort of like the prototypicals, right?
yep,
So remember, you can make the rate and the volume like whatever you want to make the PCO2 normal. The question is, if that is dangerous, like if we're ventilating with high pressures, we're putting the patient at risk for bowel trauma, volume trauma, and like hemodynamic collapse in general, right?
yeah,
So this idea of permissive hypercapnia that was sort of, born out of like ARMA with ARDS is that we allow the patient's PCO2 to rise to somewhere like around 80.
hmm,
We allow the pH to drop to somewhere close to 7.2. Now, you've probably seen patients who've had a pH of 7.25 that are like completely falling apart, right? So that we can't,
yeah, yeah,
we're sort of, we can't really, if the patient's not tolerating it, they're getting more hypotensive specifically,
yeah,
then it's not a great idea. Some patients tolerate permissive hypercapnia quite well, right? We can get them to 7.2. With APRV, remember, when we have like conventional ventilation, like VC, PRVC, whatever it is, their inspiratory time is like, let's say, zero point 0.8, right?
hmm,
When we flip them to PRVC, I mean, sorry, to APRV, when we flip them from volume control with an inspiratory time of, let's say, zero point 0.8 seconds, right?
yeah, yeah,
We flip them to APRV, and honestly, an inspiratory time of like 2 seconds would sort of be not even long.
yeah,
They're not ventilating, at least initially, fast enough because their lungs compliance really stinks. We haven't recruited lung for gas exchange. So,
hmm,
and you're making their inspiratory time longer, and we're not exchanging gas in inspiration. So their PCO2 is naturally going to get higher from whatever you started at until you recruit lung. So
yeah,
the only thing you can do to offset that is to play with your times, either like to
yeah,
make to play with your time to make the patient breathe faster. But then there's a question of like if you're using APRV with a longer inspiratory time to recruit lung, but you're cutting that inspiratory time short to make your rate faster, then like what are you really achieving, right? That's like sort of
yeah,
like the eternal question with APRV. So
yeah,
you're absolutely right. You're absolutely right. If you were on PRVC, let's say, right, and your pH was like 7.3, and you're going to flip them to APRV, you're certainly going to take a hit with your
for sure.
PCO2 and your pH. So you have to be ready for that. And if you split them and their acidosis gets worse and like they were on 2 of norepinephrine, now they're on 40, like
Yeah.
they're really maybe not tolerating APRV. You know what I mean? So you might
Yeah.
not be able to, like, not everyone is a great candidate for it. The APRV gurus will say that you have to like they got to ride it through and they'll be fine and you just have to recruit and blah blah blah. But again, the best vent mode is the vent mode that everyone understands. So
Yeah.
if no one knows what the hell you're doing, and not to mention, don't forget, I'm only there how long? 12 hours out of the day, like at the
Yeah.
most, right? Like there's a whole another 12 hours where I'm not there. And if
Hmm.
I'm the one that knows how to work APRV and like Nick's at home and like the night intensivist maybe isn't as nimble with it or the night RT doesn't understand, then like how does that really help the patient if only
Yeah.
one person knows how to run it?
For sure. For sure. No, that's a really good point. Something that I don't really think about because I'm not like in charge of which vent mode is selected. Obviously I can
Yeah.
make suggestions or think about things, but um yeah, no, this has actually been super insightful. I feel like we need to do another episode. If you want, we can, because I feel like
Oh,
we
I
only like
don't, we can,
scratched the iceberg, or
we can
what do you
do
call it? Scratch the
the tip of the
surface.
iceberg. We can do, we can do it much more. I would love to have you back on. We can ask a ton of questions. I know it's my fault because I like ramble on and on because that's like kind of my thing is like rambling. But
No, you're
as you
good.
know, right? Because like the doctors just ramble. But because I think that's the other thing with vets. It's like hard, you know, like you start talking about it, and then like I feel like the more you talk about it, everyone just like glazes over. So you really
Yeah.
you need it like little increments because if you do too much at once, like everyone sort of checks out mentally. So
Yeah.
this is like been an issue with like when I'm teaching it to learners, like I have to constantly go over like this is what it is and this is what we're doing, that kind of thing. So
Yeah.
no, but
No, I think
whenever,
this is
dude,
good.
whenever you want, like is fine with me, and I really appreciate your time and like
Yeah.
reaching out and stuff like to your followers to get questions and because I would love to know like what nurses want to know because I know on rounds it's hard to ask like, hey, Dr. Smith, like what's APRV and like
Yeah.
like they
For
might not
sure.
know, right? And then they get kind of self-conscious sometimes about it if they're not comfortable explaining it, and then
Hmm.
they don't want to look stupid. So then they give you an answer like, "We didn't use it in fellowship, so I don't use it now." Right? That's not like a
Yeah.
satisfying answer, right? Like that's not. It's kind of a cop out in my
For sure.
what I
For
think at
sure.
least. So
I think it would be like having an episode even just going through like the basics and fundamentals too, because that's like something that I think a lot of nurses like they don't, when they come into the ICU, or even if they've been there for a while, they don't understand what actually is PEEP, or like what is a peak pressure or plateau pressure, or
yeah,
like we're looking at your inspiratory pressures, your expiratory pressures, and your minute ventilations, and all of that. Getting even more basic is super helpful for a lot of nurses. So I would be totally down.